Hi everyone. In this presentation, we are going to discuss some commonly known respiratory infections: influenza, severe acute respiratory syndrome or SARS, and COVID-19. Before diving into these infections, I wanted to briefly review the anatomy of the respiratory tract. This way we can be mindful of where they are taking place in the body. Additionally, we can follow the general pathway of a pathogen following inhalation. The respiratory system can be divided into upper and lower portions. The upper respiratory tract contains the upper airways, nasal passages, oral cavity, pharynx, and larynx. When you inhale through the nose, air travels through the nasal cavity into the nasopharynx, then through the oropharynx and laryngopharynx. Once this air passes under the epiglottis and into the trachea, it reaches the lower respiratory tract. The lower respiratory tract includes the trachea, which slits into the left and right main bronchi. The bronchi further split into bronchioles, terminal bronchioles, alveolar ducts, and ultimately alveoli, where gas exchange takes place. As pathogens travel through the respiratory tract, they meet host defenses that work to prevent them from attaching and initiating infection. Goblet cells in the respiratory epithelium produce a sticky mucus layer, which hinders microbial attachment to underlying cells. The respiratory tract also contains ciliated epithelial cells. The beating motion of the cilia remove and transport mucus and trapped pathogens upward towards the epiglottis. Once this occurs, the individual can swallow or cough it out. This process of eliminating pathogens is called the mucociliary escalator effect. It is an important mechanism that prohibits inhaled pathogens from traveling deeper into the lower respiratory tract. The upper respiratory tract is constantly monitored by mucosa-associated lymphoid tissue, or MALT, including the adenoids and tonsils. Other mucosal defenses are secreted immunoglobulin A, lysozyme, surfactant, and antimicrobial peptides known as defensins. The lower respiratory tract is protected by alveolar macrophages, or phagocytes, that effectively kill pathogens that escaped the other defenses. I wanted to address these host defenses as they will provide some context for the disease mechanisms of influenza, SARS, and COVID-19 as we move forward. Influenza, often referred to as the flu, is a common viral infection that affects both the upper and lower respiratory tracts. The causative agent of influenza is influenza viruses, or more specifically, orthomyxoviruses. The influenza viruses are RNA viruses of the orthomyxovirus genus. Influenza viruses are spherical or filamentous enveloped particles 80 to 120 nanometers in diameter. The RNA genome of this type of virus presents as 7 to 8 segments. Each segment is coated with ribonucleoprotein and encodes one or two specified viral proteins. The influenza virus is enclosed within a lipid membrane envelope that is covered in spike proteins, hemagglutinin, and neuraminidase. These spike proteins are significant contributors to the viral infectious cycle. The three major groups of influenza viruses are categorized as A, B, and C. They make up 3 out of 5 major groups of orthomyxoviruses. Influenza A viruses are the most virulent group, as they cause seasonal pandemics of influenza every year. Influenza B virus is less virulent and can be affiliated with epidemic outbreaks. Influenza C virus typically produces the mildest symptoms and is sporadic in its spread. Influenza viruses are transmitted from person to person, primarily through respiratory droplet transmission, like when an infected individual coughs or sneezes around a vulnerable individual. In other words, these viruses are transmitted in aerosols of respiratory secretions. Indirect or famine transmission can occur as well. For instance, when an individual touches a contaminated surface and proceeds to touch their face. Influenza viruses multiply in the respiratory mucosa. To initiate the multiplication process, the orthomyxovirus binds to host cells via hemagglutinin. Next, transcription and nucleocapsid assembly occur in the nucleus. Progeny virions assemble in the cytoplasm and protrude from the cell membrane, killing the cell. In cells that are simultaneously infected with more than one parent virion, genome segments may undergo reassortment, and thus cellular destruction and inflammation occurs. Symptoms of influenza are fever, headache, aches and pains, fatigue, nasal congestion, and sneezing. As you can see on this chart, fever, aches and pains, and fatigue are the most severe for influenza, where nasal congestion and sneezing are rare, and headache is common. Diagnosis of influenza is typically performed using a variety of rapid influenza diagnostic tests. These tests provide results within 15 to 20 minutes. Because of that, they're not the most effective, and sometimes they can produce false results. Other tests include hemagglutination of erythrocytes or complement fixation. Detection of patient serum antibodies against influenza viruses is found in blood samples as well. Annual seasonal influenza epidemics result in around 290,000 to 650,000 deaths worldwide and infect up to 20% of the population, depending on circulating viral strains. Global levels of seasonal influenza have reduced in recent years due to COVID-19 restrictions of mask wearing and social distancing. During the first half of March 2021, the World Health Organization found 375 positive influenza specimens among 291,427 specimens from 85 countries. The only influenza pandemic in the 21st century was swine flu, caused by the H1N1 virus. More than 214 countries were affected, with 284,000 deaths, of which 18,449 were laboratory confirmed. Hong Kong flu caused 1 to 4 million deaths in 1968. Asian flu caused a similar number of deaths between 1957 and 1958, and the Spanish flu caused 20 to 50 million deaths in 1918 to 1919. Between 2010 and 2020, several cases of human infection from bird flu strains have been reported. Three drugs that inhibit influenza neuraminidase activity are inhaled zanamivir, oral oseltamivir, and intravenous peramivir. If these drugs are taken at onset, they can shorten the course of the disease. These drugs are believed to impair the ability of the virus to efficiently exit infected host cells. A more effective preventative method, though, is yearly vaccinations. In fact, most of the influenza vaccines over the past decade have had an effectiveness of about 50%. Severe acute respiratory syndrome, or SARS, is an acute respiratory infection that infects both the upper and lower respiratory tracts. The causative agent for SARS is coronavirus SARS-CoV. The genome SARS-CoV is a large positive sense single-stranded RNA consisting of 29,751 bases. Phylogenetic analysis uncovered that this coronavirus was moderately related to other known coronaviruses, including 2 human CoVs known to cause common colds and lower respiratory infections. Bats and civet cats are believed to have been the reservoirs for SARS. This disease originated in southern China during the winter of 2002, before it quickly spread to 37 countries. Within a year, over 8,000 people experienced influenza-similar symptoms, and about 800 people died. The outbreak was controlled the following year, and no further cases of SARS have been documented since 2004. That remained true until 2019, when a similar coronavirus, SARS-CoV-2, provoked COVID-19. But we will further discuss that later on. SARS is an airborne virus that transmits and infects a host via mechanisms similar to those of influenza. SARS-CoV can spread through aerosols of respiratory secretion, specifically small droplets of saliva. Additionally, SARS-CoV may be spread indirectly through surfaces that have previously encountered an infected individual. Symptoms of SARS are high fever, specifically a temperature greater than 100.4 degrees Fahrenheit, headache, overall discomfort, body aches, mild respiratory symptoms at outset, diarrhea in 10 to 20% of patients, a dry cough may develop after 2 to 7 days, and most patients develop pneumonia. Diagnosis of SARS is based on risk of exposure. In the absence of person-to-person transmission, diagnosis is considered for patients who require hospitalization for unexplained pneumonia and have epidemiologic history that raises suspicion of exposure. Once person-to-person transmission has been confirmed, the measures taken in the absence of transmission still apply. But additionally, patients with fever or lower respiratory symptoms should be questioned about close contact with an infected individual, history of foreign travel, and exposure to an infected domestic location. Patients who have this exposure history should be evaluated for SARS-CoV, according to the algorithm on the next slide, which involves radiographic testing and isolation precautions. So as you can see in this image, the algorithm for fever or lower respiratory symptoms for SARS-CoV is expressed. And like I stated before, radiographic evidence as well as isolation practices are heavily focused on. SARS originated in southern China in November 2002 and was brought to Hong Kong in February 2003. The disease spread rapidly worldwide from there, mostly to Asian countries. In June, the global cumulative total was 8,422 cases with 916 deaths, with a case fatality rate of 11%. People of all ages were affected by this disease, but predominantly women. The risk factors for death included old age and comorbid illnesses, especially diabetes. Isolation measures to prevent spread of disease are used in order to treat SARS. Severe cases often require hospital stay, especially if breathing issues form. Many medications, including corticosteroids and antiviral medicine ribavirin, have been used, but there is no known medicine to cure the illness. COVID-19, or coronavirus disease 19, is a disease that causes respiratory symptoms that can feel like a cold, flu, or pneumonia. COVID-19 may attack more than your lungs and respiratory system, though. It can affect other parts of the body, too. As we know, this disease is very contagious and has quickly spread around the world since 2019. The causative agent for COVID-19 is SARS-CoV-2. SARS-CoV-2 is part of the coronavirus family. This family includes common viruses that produce varying diseases from head or chest colds to more severe rare ones like SARS, which we have just discussed. The word corona translates to crown, which refers to the biology of these viruses. Coronaviruses possess spike proteins, which poke out from the virus. If you remember, we addressed these spike proteins earlier when discussing the characteristics of influenza viruses. Interestingly, SARS-CoV-2 is a virus that can continuously evolve as changes in the genetic code occur during genome replication. Since the beginning of the COVID-19 pandemic, genetic lineages of SARS-CoV-2 have been developing and circulating worldwide. They continue to be routinely monitored through investigations, laboratory studies, and so on. You should have heard of Omicron and/or Delta as variants of concern at some point. Fortunately, no variants of high consequence have been established in the United States. Additionally, vaccines have been developed to be effective against these variants. We will touch more on vaccines as we move forward. SARS-CoV-2 enters the body through the nose, eyes, or mouth via aerosols of respiratory secretion. Similar to SARS-CoV, the spike protein binds to the ACE2 receptors on type 2 pneumocytes in the alveoli in the lungs. Once the ACE2 receptor binds, the virus is permitted to enter into the host cell. This is due to host cell proteases that cleave the spike protein of the virus, and thus, the virus enters the host cell via direct entry by membrane fusion or by endocytosis. Where a typical flu virus travels to the nucleus once it enters the host cell, SARS-CoV-2 releases its positive sense RNA into the host cell cytoplasm. This RNA is translated into polyprotein 1A and polyprotein 1AB, which aid in replication and transcription of viral RNA. Transcribed mRNAs can be translated to produce viral proteins. The host cell endoplasmic reticulum carries these proteins to the Golgi apparatus, where they are packed into vesicles and organized near the host cell membrane. The new viruses that form exit the host cell via exocytosis to infect other cells, and this process results in host cell death. Common symptoms of SARS-CoV-2 are fever, dry cough, fatigue, and headache. Less common symptoms are body aches, sore throat, diarrhea, conjunctivitis, skin rashes, loss of taste, and loss of smell. Very severe symptoms are shortness of breath, chest pain, loss of speech and loss of movement, bluish lips and bluish face, and the inability to stay awake. Major categories of diagnostic methods available today are as follows. Molecular testing can be used. This involves a throat swab, which is preferred because it's non-invasive and contains high concentration of the virus. This swab is followed by the RT-PCR test, which is the most common and reliable with relatively high specificity. Serology testing can also be used. This is when blood, plasma, or serum of the patient is taken and tested for immunoglobulin M and immunoglobulin G antibodies. Rapid antibody testing is now available as well, and it can even be done at home. Finally, imaging can be used. This involves chest x-rays and CT scans, which are additional to the RT-PCR tests. By using these scans, we can see the progression and damage due to COVID-19. However, they cannot always determine the disease. The first reports of COVID-19 were made in Wuhan, China. Since the end of 2019, over 500 million confirmed cases have been reported around the globe. Reported case counts underestimate the overall burden of COVID-19, as only a fraction of acute infections are diagnosed and reported. One study suggests that over 3 billion individuals, or 44% of the world's population, had been infected at least once. 1/3 of total cases were approximated to have occurred in West Asia, including India. The main mode of SARS-CoV-2 transmission is person to person. In order to treat mild to moderate COVID-19 in individuals who are more likely to get sick, we can use 2 different types of treatment. One being antiviral treatments. They target specific parts of the virus to halt its multiplication in the body, and they help to prevent severe illness and death. The other treatment is monoclonal antibodies. These help the immune system recognize and respond more effectively to the virus. COVID-19 vaccines and boosters are highly recommended as a preventative medication for the disease. And that brings us to the end of the presentation on these respiratory diseases. And in the following slides, you can see all of the references that I used. Thank you.